Thanks for the invitation to both of you guys. So I got tasked to talk about disaster and humanitarianism response, which actually I would say I knew something about disaster response. I've really been more on the humanitarian side. And like our previous speaker, I started in service, and I think a lot of us move because I think the impact is better and in education. My only disclosures, I really have none. I have worked for Doctors Without Borders, MSF. I run a bunch of programs, but that's about it. So disaster, this is sort of an agreed upon definition. It's a calamitous event. It disrupts what's happening. It's economic, environmental. Society can't cope with it. It's most often caused by nature, but you can have natural origins to it. And you know, this is the Nepal earthquake. We just saw pictures from the Haiti earthquake. These are devastating events and actually take a different type of response. Humanitarian crisis, and this sometimes gets confusing because we use the word humanitarian disaster. But if you actually think about these, there are different skill sets. So this occurs in a country or region. There's breakdown of authority, and it's internal, external conflict. And this is bigger than any one country or area can handle it, so there's international actors that come in. It can be both natural and man-made, and when you look at this, you see extensive violence, loss of life, displacement of populations, widespread damage to societies' economies. Many players come in to help with this humanitarian response, and there's significant security risks. So I have actually spent a huge amount of my life dealing in exactly this situation. And this is, I think, right now the largest humanitarian crisis. This is Syria, where as physicians and healthcare workers, they were being selectively murdered and killed. And you can imagine the population really having no access for that. So is disaster and humanitarian in this definition for you? So are you trained and competent for the scope of the needs? Are you comfortable in an austere and risky environment? So I have been in the Congo during their wars. I've been in multiple countries where my nurse has been murdered. We've been shot at. This is not for everybody. Are you willing to work outside your comfort zone? Are you flexible, creative? You need really diverse cultural competency because you're working with teams of many different types of people from many different cultures, and you really need a make-it-work spirit. And this is actually a paper that was published, I'd never even heard of this journal, the Journal of Interprofessional Care, but they actually looked at non-technical skills for a surgeon here. And you can see they really broke them down into you're in an austere environment, you need cognitive strategies and interprofessional skills. And everything on this list, I would say, is absolutely critical in my own experience. The sense of humor thing, I mean, you know, I'm in Africa, and we're trying to get, you know, you're on the American time, and you're like, let's get some cases done, let's get some cases done. And I had to learn the expression, it's 15 heures. Well, that means it's 3 o'clock in the afternoon, and we have to shut down for a while because it's 15 heures. And, you know, you have to eventually just develop a sense of humor about that. So this is sort of pictures from my life. You know, you have to be able to want to take a bath outside at times. That is a high-class toilet in many places. I mean, you're lucky sometimes if you have that. Those may be the entire supplies that you have to do your work because you're not bringing in supplies. Oftentimes you're having to use what you can find. And I didn't actually know that you could create suction by pumping it with your foot, but that is a suction machine, and you will find that places. So you really have to be able to achieve the satisfactory end result when you don't have everything around you that you're used to. And this is really a challenge for some people when they go from high resource settings to low resource. I've seen people they've only used stapled bowel anastomoses. They don't know how to sew it. You don't have energy devices. You have the reel of suture to tie things with. So it's a bit different. So when you want to work in disaster, you've got to be able to deploy on a short notice. There is no advanced warning for a tsunami. So you've got to be able to deploy fairly quickly. I think it's really, if you want to work in disaster, you need to belong to a response team. And there are response teams around the country that are always looking for competent people to join them. And if you think about it, you have to have a cache of gear and equipment, because in a disaster setting, you're flying all that with you, and then you're setting up your own hospital. So I've actually gone through some disaster response training where we literally set up a hospital out in our like the green field around our hospital, and then actually ran simulated patients through it, because you have to do infrastructure, facility, triage, where are you putting your triage, who's getting in, and all those things. And you really do have to do this pre-deployment training to be prepared. Now, it's not often that I will say that orthopedic surgeons have done a better job than we have, but this is actually one of the situations. This is the AAOS, the American Association of Orthopedic Surgeons, and they actually have a volunteer database that can go out in orthopedic disasters, so especially earthquakes, things like that, at a moment's notice. And if you look at this, they have an incredible schema of, I'm not sure, oh, there's the laser thing, of what do you have to do. You have to be trained in these different courses, it's required, you have to have ethics, all these things. Are you in the immediate phase, or are you in the sustained reconstructive phase? They have different courses that you can take. They actually then will credential you, so they know that when you're going out, that you actually know what needs to be done. I actually think that we should be doing something like this if we want to get into this area. So Haiti's already been brought up, and I'm going to talk about Haiti from a bit of an orthopedic standpoint, because Haiti in many ways was a double disaster. We've already heard about how many people were injured, and then there's this timeline. The immediate is just like the picture we saw. Immediately badly injured people are not going to survive. There is no health system to activate for them, and those people die. So now what you're getting into, the people who need immediate treatment within days, so you have time to get teams there, and then weeks as the needs go on. And the wounds and fractures and amputations and infections, basically that's what it starts off with. But since there's no health care, now as you go later and later, you get into the fact that women need cesareans and all this other health care that isn't happening. So when you look at what happened in Haiti, more than 600 health agencies went, individual MDs, out of the goodness of their heart, just picked up and flew down there. There were disastrous problems with communications, and really the untold story, because it's just a bad story, is, especially in orthopedic, they were the best-hearted people who went down, and they kind of violated a principle of humanitarian disaster, which is you don't open closed fractures in poor environments. Like when you're operating outside under a tent in a shipping container and you can't really guarantee the sterility. So closed fractures got treated in an open manner. That's what we do here. And those patients then got infected hardware, amputations, and that was really the double disaster that hit. People took first really high resource principles and applied them in the wrong setting because they weren't trained. So when I look at what's humanitarian surgery and the definition of what we're saying, what I'm calling humanitarian surgery, this is if you want to really go out with the ICRC, Doctors Without Borders, I call it the loose rule of thirds. It's a third orthopedics. It is always going to be orthopedics. OB, in a single 4-week period in the Congo, I did 70 cesarean sections. It actually helped my general surgery practice because I know how to do a fan and steel really well now. And then the rest kind of falls under general surgery. When you look at what the WHO calls essential surgical care, obstetrics and management of postpartum hemorrhage is a key component of this. All right, all of us should know how to do laparotomies. Amputations, you can actually, okay, surgical treatment, abdominal trauma, hernia, ooh, there's that orthopedics again. Burns and complex wound, you have no wound vac, you have no magic wound stuff to put on things, so you gotta figure that out. I don't know why that one went back. But airway, all these things. Burr hole. This is what the Disease Control Priority 3 sort of lumped it into 3 areas. It's really OB, general surgery, and injury. And I think all of us would feel really comfortable right in that middle section, right? Some of us will still feel comfortable in this area, but when's the last time anybody in this room did a burr hole? Non-image guided, right? A little bit different. So if you look at what are we taught as general surgeons, these are the current requirements. They're actually different than when I trained, because I did surgical subspecialty training. There is no rotation required in burns, obstetrics, neurosurgery, urology, orthopedics, or thoracic specialties. And when you look at the graduating chief resident counts of what these are essential for being able to go into a humanitarian setting, you can see that outside of amputations, not a single graduating, this is the average number, national average, we're not doing this, right? This is just not what we do. So is our residency good preparation for this? And I'm gonna say no. We don't do C-sections. We don't treat orthopedics. We don't really do burns, not in this type of setting. And we're all becoming much more subspecialized. And of course, you can't get in the hospital without getting a CAT scan or some other kind of scan. So we've become very reliant on our tests. So I think that general surgery residency at this point in time is not optimal training if this is the career path or you want this part of your life. So learning on the ground is really not the best option for patients. And it can be psychologically, it's very hard when you are so out of your comfort zone trying to do something. So how do you get trained if you want to do this? This is actually pretty tough. There's not a lot of opportunities for this type of training. The disaster people actually have this much better organized. Probably the most famous class are the DMEP classes. And then when you look at this, you look at what they're talking about. It's burn, blast, mass casualty, weapons of mass destruction, all of that. There's the IMC, which is an NGO, that's the group that I've worked with for disaster response. There's some medical disaster response courses, but this is something you really have to actively go out to seek this type of training. Humanitarian's actually even harder. There's didactic online courses which talk about what a humanitarian crisis is, the components, how you have to think about it. I've actually run the largest and longest running humanitarian surgery course going since 2010 now. There's a great course in Britain, the Surgical Training for Austere Environments. It's a week-long course. And then the ICRC and MSF run like day-long or occasionally longer courses every now and then for their people. But this is not easy to try and find this. This is actually what we teach. I wish I could teach more. Part of it's trying to figure out how do you teach it. But we talk about resource management, making sure that you look at what do you have, because you must make decisions by what you have. We talk about tropical medicine because you're going to see diseases that have surgical implications. I'm sure in Haiti you've seen a lot of tetanus. I've seen tetanus almost everywhere I've gone, and I didn't recognize it the first time I saw it. How do you talk about low resource anesthesia, right? Our favorite drug for all laparotomies, ketamine. Ketamine, we could not work without ketamine. How do you do wound and burn care when you don't have dressings and all sorts of things like that? We teach a lot about orthopedic trauma. So we teach traction, which will take care of almost any injury, X-fixing, burn excision, split thickness skin graft. The first time I asked for a dermatome, it was in a French-speaking country. I'm like, do you have a dermatome? They're like, oui. And I'm like, well, can I have it? And they handed me a knife this long. And I'm like, can I have the dermatome? And they're like, it is the dermatome. So we actually teach people now how to use the knife that's this long to hand cut a skin graft because that's what you're gonna get. So we do teach blind burr holes. So we have a whole course on this, and then we spend a half a day teaching how to do C-sections. A B-Lynch is a innovation in how do you control postpartum hemorrhage, how do you make your intrauterine tamponade devices, how do you deal with D&Cs, how do you take out breech babies, transverse babies, all this. And when you have a patient who's bleeding after a C-section, which unfortunately is not uncommon, it's one of the #1 causes of maternal death is postpartum hemorrhage, how do you do that hysterectomy? We actually just completed the course at Stanford just a couple weeks ago, and that's sort of the whole schema, but this is not for everybody. It is demanding, and this may not be how you want to work. You know, I know people who go out and, you have a hernia practice, and there are great opportunities to go and teach and do hernias in low resource settings. Disaster and this humanitarian type of practice is not. You've got to be comfortable being the everything surgeon. I joke, everything from a dentist to a neurosurgeon. And you've got to be that MacGyver, which, by the way, the Oxford English Dictionary now has a definition of, which is you make or repair in an improvised manner. So there are other opportunities to volunteer in educational and procedure-focused trips, and if that's a better fit, do it. If you want to do humanitarian and disaster, get trained for it. Thank you very much.